Hello and welcome to Paincast, Conversations on Pain and Physiotherapy. This podcast is brought to you by the Pain Science Division of the Canadian Physiotherapy Association. I'm Tiffany, the host of Paincast and an executive member of the Pain Science Division. I practice physiotherapy in Toronto. In this episode, I work with one of the students I mentor in the Pain Science Division Student Committee to develop an episode on a topic of interest. I will pass it on to Steph.
I'm Steph, a second-year physiotherapy student from the University of Alberta. What are some non-pharmacological management options for neuropathic pain? What is the somatosensory rehab method? Who is it for? And how do we do it? How should we go about allodynia? Where is the current research at with somatosensory rehab? We address these questions in part 1 of our chat with Dr. Tara and Packham. Before we start, as a reminder, Paincast brings together researchers, clinicians, students, and patients to facilitate discussions, knowledge translation, and critical thinking on topics about pain and physiotherapy. The views expressed in each episode are of individual guests, do not constitute medical advice, and do not represent the views of the Pain Science Division or the Canadian Physiotherapy Association. Enjoy the episode. Could you introduce yourself to the audience, what you do, and maybe something exciting you've been working on?
I'm Dr. Tara Packham. I am an occupational therapist by training. I'm currently an assistant professor in the School of Rehabilitation Sciences at McMaster University. One of the things that I'm enjoying a lot right now has to do with my hand rehab background. I'm working with some biomedical engineering students, and we are developing a pediatric device for measuring grip strength that's also a toy.
That sounds very cool. Our episode today is focusing on neuropathic pain. So what's your interest regarding neuropathic pain?
When I was in practice, it was an area that I found really interesting. And even coming from my first job was actually in rheumatology, and pain and inflammation were huge parts of what we were addressing. So I think that probably has sensitized me a little bit to that. And I went back to graduate school to look at complex regional pain syndrome, which is certainly a particular form of pain. And you'll get in trouble if we call it neuropathic pain from the IASP point of view. But what got me interested is more the complex pain part. Is this idea of pain that really isn't playing fair, right? From the person's experience, where the pain has changed and is changing what they're able to do and how they're able to participate, and often changes how they're viewing themselves as a person. So I think that complex pain was really interesting to me and felt like the group that I wasn't making the biggest difference for in my patient population. I loved working in hand and upper limb rehab because many of my patients got better. And we were able to help them through from a traumatic injury that upended their life and walk them through really getting back to doing everything. Maybe not exactly the way that they did everything before, but really seeing substantial recovery. And folks who had complex pain maybe weren't the group that were the most successful. And so I think that was what was challenging for me.
Do you feel like you've been able to achieve what your passion was back then, to be able to be more effective with people with complex pain?
I'm on the journey. Do I feel like I've made some changes and helped to lead some change? I hope so. Certainly one of the things that got me really interested was feeling like we didn't do a very good job of measuring pain, that we weren't capturing the things that were important, particularly in the area of CRPS, complex regional pain syndrome. I felt like we weren't doing a great job at capturing not only the person's pain and other symptoms, but how those impacted their daily activities, how they were managing and coping with their symptoms and pulling in, because we recognize it's a whole impact on well-being. That includes mental health challenges at times. Anxiety and depression are common co-travelers with chronic pain. And so really trying to unpack that, I think, was something that I was really passionate about. And I hope that we've made inroads into starting to do that. I think pain is an invisible disability. And so that is one of the challenges, is how do we help people capture that to feel like they're being heard in their experience as well?
Absolutely. So right now, obviously you're a professor at McMaster University. Do you still do clinical work?
I do not. COVID ended my clinical practice. I had continued to do some clinical care until that time. And then it was just really challenging in terms of not wanting to cross-contaminate between serving students and serving the public. So I haven't done any clinical practice for a few years now.
We make impacts to the rehab world in different ways, and certainly the research is a very important part of it.
Absolutely. I think that was really helpful. One of my mentors, Joy McDermott, we had a frank conversation about what point do you not stay working as a clinician? She was still able to find those things in her research. And I think that was encouraging for me to hear.
And being on a podcast to share all the knowledge combined with the many years of experience you have to share with the next generation of clinicians.
I'm privileged to be able to still interact a lot with my clinical colleagues.
Getting into our topic today, let's start with sort of an overview of the approaches to managing neuropathic pain. Neuropathic pain, in case our audience is not familiar with the IASP definition, it's defined as the pain caused by a lesion or disease of the somatosensory nervous system. So this can be from trauma, like amputation or surgery. It can be from disease, diabetic neuropathy. It can be from changes to the central nervous system, like stroke, spinal cord injury, changes to the peripheral nervous system, carpal tunnel, etc. So there are many causes of neuropathic pain. Now, as rehab practitioners, those who use non-pharmacological approaches to managing pain, what kinds of neuropathic pain can we have the ability to manage?
We often talk about classifications of pain, and we talk about nociceptive pain, neuropathic pain, and nociplastic pain as kind of one of the main categorizations. And I would insert in there is also probably a category of inflammatory pain. And then we can look at those and say some of those are acute states and some of them are chronic states. So we see chronic neuropathic pain, but we also see acute neuropathic pain. Nociplastic pain is rarely seen in the acute stage, although it can be. It tends to be more that chronic pain. The other division that maybe if we look beyond, is it an adaptive response of the body or is it a pathological response? Has it become maladaptive? And I think a lot of the approaches that we have been most comfortable with in rehab have been trying to address neuropathic pain on that acute adaptive end, right? Somebody has a known nerve injury and we say, yes, you're going to have some dysesthesias. Things are not going to feel normal and it's going to be uncomfortable, but we can retrain, do sensory re-education, and we expect that we'll see resolution of that. I'm speaking from my own experience in hand and upper limb rehabilitation in particular. I think where we struggle a little bit more is with that maladaptive chronic pain where there's this overlap of nociplastic features and neuropathic pain. I think that tends to be the more challenging area because we know that nerve injury often doesn't just impact the sensory experience, it impacts muscle. And I think as rehab, we've tended to focus a lot on movement and muscles and maybe don't prioritize the sensory recovery parts as much. That applies across stroke and spinal cord and peripheral nerve injuries as well.
So in terms of the confidence in treating and getting people better, we have an idea of how that looks like in more so the acute neuropathic pain type where, let's say, you have a nerve injury from surgery or a cut.
Even things like carpal tunnel syndrome, we have a mechanism that's clear to us. If I address this piece, I'm going to restore the blood flow, whether that's through surgery or whatever that is, we're going to be able to change things, no problem. We have a clear pathway. I think it's the complexity that is more challenging to address when we see that more complex pain, where the person is maybe not just experiencing sensory loss or dysesthesias, but maybe has some sensory gain like allodynia and summation. That's, I think, where it becomes more challenging.
Yeah, we'll certainly get more into that, where allodynia is also a part of the topic we're talking today, like how do we treat that as well. So you have spoken a lot about somatosensory rehab on different occasions. Briefly speaking, for those who maybe perhaps never heard about somatosensory rehab, what is that?
So somatosensory rehab is a method. So it's both assessment and interventions combined. Claude Spiker, who developed the idea, would describe it. It's a treatment method, not just an intervention approach. And it's intended for people who have painful numbness. So really, it is intended to be a form of treatment for neuropathic pain. And what I found really interesting when I first heard Spiker talk about his work was the idea that he was really being strategic about how he was assessing and really identifying when do people have painful hypoesthesia, painful sensory loss, and when do they have sensory gain. And then saying, okay, these are two different presentations, let's address them differently. And so that really appealed to me because I was thinking, that resonates, that particularly this group with sensory gain are the ones that I'm not sure I do a good job with. So that way he was thinking about it really resonated with me. And his essential thesis was we need to address allodynia. We need to address that sensory gain. When we do that, we'll actually unmask residual sensory loss underneath it. That really, when we address that sort of sensitization aspect, then we go back to more the mechanical transmission aspects, and we can actually get in and address that and think about that in a different way. But what was also radical was the idea that we actually need to not provoke pain and that we need to mitigate evoked pain to not continue to reinforce the negative neuroplasticity. The system changes and becomes sensitized, and that changes in the brain and how we are perceiving and dealing with sensory information. If we're just continuing to have people push through, we've all encountered those clients, right? That the more we ask them to do, the worse things get. They just seem to flare, or they'll come in and say, I didn't do anything and my pain is worse. And I think that's challenging because we know exercise can be really helpful for managing pain, but it's not helpful for everybody. For me, this was a helpful way of starting to think about that, to say, well, how do I actually pick out the people that are going to respond one way versus who are going to respond another way?
That is very interesting, and we will definitely get more into differentiation and how do we manage each aspect. So it's a method that combines assessment and treatment. How was that method invented? Dr. Spiker, how did he come through the process of producing this method?
Spiker is an occupational therapist and actually has a background in hand and upper limb rehabilitation as well. Sort of a kindred spirit in that way. He was really recognizing that he was seeing these differences in presentation. And I think one of the things that he really was thinking deeply about was the presentation relative of pain, where the person was experiencing pain and symptoms relative to the area of nerve injury. So when he was seeing this mismatch where the person had regionalization of symptoms, which is certainly what we see in complex regional pain syndrome, but we know that we see that with other nerve injuries as well. David Butler has used the term smudging, this idea that where we're perceiving the borders, the boundaries of the territory of sensory change are not what we would anticipate as being textbook based on a nerve injury itself. The person has change in how they're responding. And so I think he was trying to think about that and say, well, how do I address that? And if the normal dogma around desensitization, flooding an area with comfortable sensory stimulation or uncomfortable sensory stimulation, how do I choose? How do I do that? And if the person isn't responding to that, what else can I do? So I think he was really thinking about how do we start to unpack which direction we should take. Do we flood an area with sensation, or do we protect it from sensory overload? And so really starting to reason that through. And I think that was really the aha moment to say, can I think about this and actually start to categorize people and identify and tailor the treatments accordingly?
Was it trial and error process, or he figured the steps out?
I do think it was initially a little bit based on that clinical evidence, but he is somebody who I think thinks in very logical patterns. And so he was really trying to break it down in terms of his work. And so started to really keep amazing records of what he was doing and how he was approaching things, and really trying to be very standardized in the way that he was taking things on. It was totally amazing. And then he started to teach and share that. But he is not a researcher. So that was kind of where my entry started, coming alongside him and saying, can we collaborate to do some research to try and build some evidence around this method?
Just a small rabbit hole to go down to. So I understand that the current diagnostic algorithm for neuropathic pain, one of the criteria is that it has to make a neuroanatomical sense. Now, when we do talk about the smudging phenomenon, how does that correspond?
That's a great question. And in Biker's answer to that was to map very methodically where he was seeing sensory changes and to say, okay, what is the biggest border that we've seen the expression of neuropathic pain for a particular nerve? And he drew on the literature from anatomical texts as well as his own assessments and has documented that and categorized that and published it actually as an atlas. This approach of saying, let's think about the very specific branch of a cutaneous nerve and what area it innervates, what's the territory, and what's the maximal territory that we have assessed it or it's been seen to have sensory change in. What's the furthest distal, what's the furthest proximal, medial, lateral, and what area is always this nerve. And so again, that was really helpful for me. That made really good sense when I first encountered that way of thinking. And conflict of interest declaration, I'm a co-author on the most recent version of the atlas. And my role was not contributing to the maps, but help people to describe the techniques that were used going into them and to support people systematically conducting those types of evaluations with their own clients as well.
Mm-hmm. Now, we're still on the track of talking about approaches to neuropathic pain. And in 2023 systematic review and meta-analysis on post-stroke complex regional syndrome interventions that you co-authored, there was mirror therapy, graded motor imagery, pain exposure, aerobic exercise being found to have certain effects on post-stroke CRPS. Are these considered approaches to treating, well, I guess we're now saying CRPS is not technically neuropathic pain?
I do think there are some overlaps, 100%. Even if we talk about CRPS, post-stroke pain, post-amputation pain, phantom limb pain, we know that there are these overlaps. There are similarities in management and approaches. And so setting aside the diagnostic criteria for neuropathic pain and talking more broadly about pain with neuropathic features. How's that?
I like that.
Pain with neuropathic features. To me, using things like mirror visual feedback and in some cases, graded motor imagery, I'll separate those as being two distinct approaches. Those can be helpful. We have better studies on graded motor imagery, but I do think that there are some reasonable quality studies, but maybe not RCTs on mirror visual feedback. And so there's as an isolated intervention.
Can you briefly explain to our audience why are we differentiating the two?
Graded motor imagery is a 3-step approach to dealing with pathological pain because it is used in phantom limb pain as well as in complex regional pain syndrome. And certainly people will use it in the post-stroke population as well. And the idea is that first step is laterality recognition. And theoretically, this is activating the premotor cortex without movement. So we're activating the cortex and we're giving the person motor planning experience, but without actually producing movement and eliciting pain. So we're starting to build those connections. The second phase is motor imagery, or mental practice is another term that our kinesiology colleagues would use. So that idea of mental rehearsal of movement without, again, actual movement happening. That's intended to be pain-free and creating the connectome in the brain. We're having some activity happen, but without actually sending a command to the muscle. And then the third part is adding in mirror visual feedback, and that may involve giving visual inputs first, and then ideally adding bilateral movement, but where the person is focusing on seeing the non-painful limb move in the mirror. The painful limb is hidden behind the mirror, but the idea is that they're seeing hopefully better movement on the non-painful side, but experiencing that perceptually because of that visual feedback as non-painful, normalized movement. And so it's really a form of sensory and proprioceptive retraining.
Why would you differentiate graded motor imagery with just mirror therapy alone?
Mirror visual feedback, some of the original papers on it in the area of CRPS refer back to Sandy McCabe and the original studies. What they showed was in people who had relatively acute complex regional pain syndrome, that doing mirror visual feedback, they saw positive responses for pain and disability. What they saw in people who had chronic CRPS, bigger changes at the somatosensory cortex level, those people didn't necessarily have a positive response. And so Lorimer Mosley's work with GMI was to say, how can we help people to get to the point where they can take advantage of the mirror visual feedback? And so he was trying to grade things back a little bit so that we could then arrive to that point. So I do think that not everybody with complex pain needs to do graded motor imagery. There are lots of folks who do fine with mirror visual feedback, but it's our job to figure out who those are, right? And so there's the challenge to say, what's going on here? Does this person need that practice, or are they able to do those activities? And what they really need is to be able to have some assistance, some visual augmentation of the signals or visual substitution to help them to improve their motion.
Okay, so now we're saying to work with pain that has neuropathic features. These are some of the options that we have: somatosensory rehab and the two that we just talked about. Pain exposure is one of them, and aerobic exercises. Are there any other approaches to neuropathic pain with neuropathic features that you know of?
Sure. I think there was a fairly recent systematic review that was published that was looking at cognitive behavioral approaches. And I would use the term approaches rather than cognitive behavioral therapy, because I think CBT has sort of a formal defined way of approaching it. It's a standardized type of treatment. And most of us in rehab aren't able to do it. We don't have the training, and we may not be in the context of being able to offer that in a way that's most effective to people. But I do think there are many times that we use cognitive behavioral approaches where we're taking principles, but we're not doing it in that formal way, because CBT is really intended to try and change the person's way of thinking, to confront unhelpful thoughts and beliefs. But I think there's lots of approaches where we start to use cognitive elements. And that can be mindfulness and yoga, acceptance and commitment therapy. And so those are some things, and we have to be careful that we're not treading into doing psychotherapeutic approaches. But there are lots of times where we're doing psychoeducation, where we're helping to change how people are thinking about something without necessarily challenging disruptive thought. And that's what we're trying to do in the area of pain.
I guess even in the population where you described the neuropathic pain complicated with nociplastic pain, a lot of it we're doing cognitive behavioral approaches of management rather than thinking of treating the pain.
Absolutely. And I think the other area that's kind of the flavor of the month right now is neuromodulation, sort of a buzzword. Really what neuromodulation is, changing the signaling. And so that might be through electrical modalities. It might be through magnetic pulses. So there's a whole bunch of different ways that people are doing that. And some are things that we can absolutely do at a rehab level. Some are things that are more on the medical side. And I think there's been a bit of fluidity in terms of some things that used to be on the medical side have now moved over into ways of delivering, like peripheral nerve stimulation. There are different ways that now we can deliver that through the skin rather than through a needle into the nerve as previous radiofrequency treatments. That's an evolving area. But I also think that's an area where we don't have a lot of RCTs. What I would say is a lot of the cognitive behavioral approaches, we've got good RCT level, now getting to the systematic review and meta-analysis level of effect. I would say neuromodulation techniques, not so much. And so that's an area where we need continued research. And I have to say, that's also where somatosensory rehab is at. We don't have RCT level evidence, and we are working systematically to get to that point, putting in all the pieces, as I alluded to, about assessment and intervention. So we needed to validate all the assessments before we could get onto that. So that's been a systematic process.
That makes sense. No wonder the 2023 systematic review and meta-analysis didn't have somatosensory rehab, because we're not at the level.
Not ready for prime time yet.
For the next part of our discussion, we're going to be focusing more on somatosensory rehab. So I know you mentioned this earlier, but I wanted to clarify, the clinical population, is that for those for painful sensory changes, or are there other populations that you'd also consider using this rehab for?
I think the population with painful sensory changes is actually pretty big. So a few weeks ago, I was having a conversation with OT on a spinal cord unit where we were talking about, is that something that we could try and implement and work to address, particularly folks who have allodynia, and how that interferes with them being able to do some of the other pieces of their rehab, and how that's an area that she felt was under-addressed in terms of thinking about recovery. So I think there's many mechanisms that bring people to a point of having painful somatosensory changes. What is the recovery capacity of somebody with peripheral diabetic neuropathy that's painful? I don't know. I think that's an area that obviously in terms of burden is a big deal, right? In terms of how widespread it is. That's not the first area that I want to tackle because I'm not sure. I think we need to build some evidence and look at areas where we think that the mechanisms and what's modifiable. Because let's face it, RCTs, big trials are hard to do. They're expensive. And so we need to really make sure that we're capturing a population that's going to make the most difference for.
Definitely, that absolutely makes sense. The last thing we want to do is provide a treatment that wouldn't be the most effective resource. So is there a way to categorize the kind of neuropathic pain that somatosensory rehab is appropriate for, or is that still waiting on more evidence to be found?
I think Spiker would argue that anybody with neuropathic pain probably would benefit. Now, is it a cure for neuropathic pain? I don't think it is. And I actually don't think that Spiker would argue that it is. But does it improve the symptoms of neuropathic pain and often help people to be able to participate in other forms of intervention that may also help to augment their recovery? Yes. And that's certainly what the evidence suggests. So there's a small study out of McGill that looked at neuropathic pain and neuropathic itch after burns. And so again, messy clinical case series data, but really the key message was that a lot of folks found improvement from using that technique. To me, that's what's intriguing. The idea that potentially there are things that we can do to address some of these areas where people haven't necessarily had really good options. I know when I first started practice, someone had hypersensitivity. The referral would say desensitize. I think that was what was challenging for me is, well, what about for the people where that doesn't work for them? That idea of pain exposure wasn't helpful. It just made them more painful. And so somatosensory rehab is really intended to help us address that differentiation to say, this group, we can start to expose them and do re-education to that area of dysesthesia, or we can address the allodynia and look at that differently.
If I were to briefly summarize how somatosensory improves patients' quality of life, it would be in regards to their symptoms and how they experience pain. You mentioned earlier participating in other interventions so that might also help improve their quality of life. Would that be correct, or is there anything else I missed?
I'm going to put my OT hat on for a second. As an OT, we're really talking about what are people's meaningful activities and what environment are they doing them in. We're thinking about this interaction of the person, their environment, and the activities that they want to do, their meaningful occupations. And so we know that the person has changes in their sensory system function, and often that means that they actually interact with their environment less. Sensation is the way we introduce our environment into our inner world. We perceive the qualities of things that we touch and interact with through the transduction of that signal through our skin, and then we interpret that at the somatosensory cortex. So there is this environment, and often people will reduce the environments and their environmental interaction as a response to neuropathic pain. They move differently, they dress differently. It has widespread effects often. And then the other part of it is, what are they able to do? How fully are they able to participate? Are there activities and even roles that they do less because of their pain? So if cold bothers them, they're not going to coach their son's hockey team because they're going to avoid that cold environment, but it's also that role that introduces them into that cold environment. So that's one that they can control. They can't control the outdoor temperature, but they can control the amount of time that they spend in a refrigerated area indoors. And so what does that look like for people in terms of trying to control that? And so I would say somatosensory rehab is not just thinking about what are their symptoms, but also a little bit bigger about what does that mean for what they're able to do. Now, at the moment, somatosensory rehab doesn't have a functional evaluation of disability that's been embedded in the method. The key assessments are pain qualities and the pain territory. I would say those are the key features that it's attending to in terms of the assessment at the moment. But moving forward, we definitely want to look at including pain disability as well.
Any measures of sensory dexterity, diagnosis, that type of stuff?
Somatosensory rehab, the initial evaluation, it really looks at where is the pain? Does that pain have neuropathic features? And so the McGill Pain Questionnaire has been sort of the essential evaluation of that. So having the person rate their pain qualities and really identifying, are those neuropathic type qualities things that people have identified? Tingling, burning, shooting, radiating, those kinds of qualities we associate with neuropathic pain. So looking at, is there a plausible neuroanatomic explanation? Looking at doing an evaluation of their sensation. And so that really happens at the level of screening for allodynia as a first step to say, does this person have pain that is evoked and where that response is to changes modality? The stimulus is light touch, mechanical stimulation, the monofilament, but the person's response is painful. There's pain in response to touch. And so if they have allodynia, and that's quantified by a painful response of at least 3 out of 10 to a 15-gram monofilament, which is mark 5.18 out of the Sims-Weinstein set. So if they perceive that as painful, then that same 15-gram monofilament is used to map the extent of the allodynia. In other words, where is it on the limb? Where's the furthest, most distal point of allodynia? Where's the most proximal point of allodynia? Where are the boundaries laterally? So that's systematically identified using testing with the monofilament. And I've found that really amazing in clinical practice because what would happen is, you would be going along, start proximally and work my way distally down the limb, sort of on the axis of the limb, the surface of the limb that they had indicated as being where their pain was. And often people would be like, oh, it's starting to change. And then the next stimulus or the one after that would be, oh, yep, that hurts, stop. That was quite interesting to me to realize, oh, yeah, that's exactly what's happening. So there's this shift in their perception. And people were able to pretty accurately and consistently report where that was. So we've mapped the territory to say this is sort of the extent of the allodynia. Then basically in the middle of that, the rainbow pain scale is used. And that's starting with the smallest monofilament in the set of 7. So we're not using the full Sims-Weinstein set of 20, but the smallest one that's used in this sort of scale of 7 for the rainbow pain scale. And vision is occluded. So the person doesn't see that they're being touched in the middle. And basically you're asking the person, say now or ow. So tell me that I've touched you or ow because I've touched you and it hurts. And so we would start with the smallest one that they're the least likely to be able to feel. And we move up progressively with testing to the first one that the person perceives as painful. And again, often what you would see is a couple of filaments, they wouldn't feel it. And then they would say, oh, I felt that one. And then you move up one more size and okay, that one hurts. It was unusual that the first one that they felt was also painful, but not unheard of. If a monofilament that you can barely feel when you have normal sensation on your fingertip where you have the highest density of nerve fibers, if that hurts more than 3 out of 10 on your forearm, that's sensitization. Again, that really made sense to me, and it was a way of quantifying and helping to make people's pain visible. We were mapping, saying this is the area where it hurts. And so that was making it visible and being able to quantify how little pressure it took to elicit a pain response, I think, again, was really helpful for people to be able to say, yeah, look, that's not normal. It was a verification of their experience. That area of allodynia then becomes the no-fly zone. That's the area where we don't want to evoke pain, and we're not going to try and stimulate or touch. Outside of that area becomes the working zone. And we try and identify if my whole area is my whole palm, maybe a little bit more on the radial side. My hypothesis is it's probably the palmar cutaneous branch of the median nerve that is the cranky nerve. That's my neuroanatomic hypothesis. So I'm going to say, how far back on the pathway of the median nerve do I have to go for the sensation to be normal? That may be up on the shoulder. So the person may not have pain on their forearm, but it may not be normal. It may not feel exactly the same. And so we want to find the normal spot, the area that's normal sensation. And that's where we're going to apply comfortable stimulation on a neuroanatomically related area. Now, it could be that it's that palmar cutaneous branch and that the distal branches of the median nerve at the tip of the fingers, which are the common digital nerves, are not allodynic. And so I might also be able to do comfortable stimulation here because that would be a related neuroanatomical path. But we would avoid doing stimulation over that painful area. So that is if we have allodynia. And so we're going to avoid that stimulation, but we're going to do comfortable sensory stimulation, or it's called distant vibrotactile counter stimulation is the formal term for that, comfortable sensory stimulation on a related pathway. And we're going to temporarily change activity patterns to minimize the evoked pain related to that as well, with the idea that should change relatively quickly. That if the person is painful to 15 grams of force, that if people do comfortable stimulation for about a month, that will resolve. This is where I wouldn't do stimulation, but I would try and also do sensory re-education as close as I could. This might be the only normal spot, but if this is dysesthetic, I would do sensory re-education on that in the meantime as well, so that we're doing both components at the same time. And then once the allodynia had resolved, usually there is dysesthesia, hypoesthesia left behind, and then we would do sensory re-education over that spot as well.
Very interesting. So there are a couple of concepts there which we will further elaborate on. But before we do that, because you mentioned it takes about a month for the allodynia to start coming down. How do we know if it's just a matter of time that the nerve needed to take time to heal?
Good question. And I would say that based on the retrospective work that we've done, often people were reporting that they had had pain for years. And so this wasn't just a technique that Spiker was using for acute neuropathic pain, but he was using it with people who had had pain for a long time. And it might take longer than a month for the allodynia to resolve, but it was about a month for every kind of level of the rainbow pain scale, roughly, was what we were seeing. I think that was what was nice about the rainbow pain scale. It gave a way of thinking about, does the territory get smaller, the allodynography? So is the area shrinking that's abnormally sensitive, but also is it becoming less intense in that abnormal sensitivity? And so you could measure change both in the surface area through allodynography, as well as seeing it take more and more pressure to elicit pain through the rainbow pain scale. And then once it was no longer allodynic, then you can do standard sensory testing like 2-point discrimination and see that indeed the person doesn't have normal sensation, that there is some sensory loss. And so then sensory re-education would be the intervention at that point. It's saying we're going to address the allodynia first and recognizing that something that needs to happen and be managed, and then we can shift. And I would say using this in clinical practice, that was one of the things that was really very rewarding, was seeing people who had kind of failed treatment in using different approaches. So they were referred to come to the clinic that I was working at because we were sort of the tertiary care center, sort of the expert area. And so maybe they had been to a community physio or a regional center and hadn't had a good outcome and were referred on, and having people come in and say, okay, you know what? We're going to try a different approach. That wasn't working for you, but that's not to say we don't think that things can change. Are you willing to try something different for a little bit? The story that really sticks out to me was someone who came who had had a wrist fusion, had an incredibly painful scar over her wrist fusion, but didn't want to take her splint off, even though her wrist was fused. She wanted to wear the splint because the splint at least covered the painful scar. And so that it wasn't getting evoked pain. And every time that she went and saw her doctor would yell at her and say, take that splint off. And so she came to me and I said, I don't care if you take the splint off. I don't believe you want to wear a stinky old splint. I think that we're going to try something different. And I'm hopeful that you're going to happily throw that splint away because you're not going to need it anymore. And she had an elbow contracture because she'd been holding that wrist out of harm's way. So we said, okay, we're not going to do all of those things that the community physio where she'd been going had been really working aggressively on her fingers. She didn't have full motion in her fingers. Let's try a different approach. Let's see how you do with this. And she bought into that approach. And it wasn't long before we could do gentle, low load, prolonged stretch at the elbow with a hot pack, and that would be tolerated. And so we were very quickly able to address what was going on at the elbow, started to be able to do more with the fingers. And then again, after probably closer to 8 weeks, she was like, okay, I don't need the splint anymore. This is feeling different. And she was very happy to get rid of it. and be able to do more because it was interfering with what she could do and feel and all of that. And after being off work for a couple of years, she went back to work. And that was like the big celebration. Now, there were some other things in her situation that, from a stress point of view, that life got better. So can we totally claim that it was somatosensory rehab? I think it was somatosensory rehab combined with some other positive things that happened in life. That's okay. That's the way life is.
That was really cool to hear that story, especially seeing that you considered the patient and you were like, no, you can keep this plant. That's okay. Kind of making her feel more safe and welcomed. One thing I wanted to clarify, in terms of hyposthesia, when that decreases, is it true that neuropathic pain decreases as well, or?
I would say that we see people who have straightforward hypoesthesia and who don't really have pain associated with hypoesthesia. And I think those folks do fine with our normal approaches. And somatosensory rehab is really targeting people who have painful hypoesthesia. So they have pain that is associated. And again, I think probably that may be more people than we realize because our clients are probably not really forthcoming about the fact it's numb and it hurts. That seems crazy. And I think sometimes they may be experiencing pain and tell us about it, but not necessarily report the numbness to the same way, because then you might not believe that they're in pain. Or the reverse is also true, where people have areas of sensory loss, and it's only if you really start to probe and say, well, yeah, and it kind of hurts too, because it doesn't make sense to have painful numbness. Maybe they were told by somebody, well, it's going to hurt before it gets better, and hurting just means the nerve is regrowing. That's the message sometimes that's been given, and so people have this expectation.
Then is it true to say if painful hyposthesia is decreasing, the pain also decreases?
Absolutely. Now, does the pain disappear? Not always. If we look at the case series that we did based on Spiker's records in people who had CRPS, some people's McGill pain scores did go to 0, but there were many people, the pain scores decreased substantially. The effect size was large, but it didn't go to 0. They still had some features of pain. Is it manageable? Yes, there's a difference. I know it's not the same as what it was before. But if we're considering if I have some residual aching and cold intolerance, is that still acceptable compared to burning and freezing pain all the time?
Do we have an idea why it's much easier to decrease the intensity and so hard to eliminate it?
Sometimes it is about the mechanisms of what's happening. So often there was some kind of a trauma. And so that may just be the residual of the trauma itself. And so we're getting that person to the point where maybe it's not perfect, but that's much better and more acceptable. And I also think that sometimes we probably don't follow them long enough in a rehab because they're not going to come and see us as therapists where they're paying for our services when we've gotten it to a manageable level. And so again, I think from a research perspective, that'll be interesting. And certainly one of our goals is to do long-term follow-ups to say, does that get to 0? Because based on clinical records where people are like, nope, I'm better. I know what I'm doing. I'm managing. I'm good enough. I think that happens often, probably in many clients we see, not just neuropathic pain clients. People know, okay, I'm on track. I feel like I'm getting there. I'm good to go.
The assessment of somatosensory rehab method has a lot to do with evoked pain. Poke with the monofilament. What's your response there? But my understanding of neuropathic pain is also that it has a lot of spontaneous pain or unevoked pain. Is that assessed and how is that managed?
I think the McGill Pain Questionnaire, that's part of it, is trying to capture those different types of pain because it asks what types of pain have you experienced in the last 24 hours and then picking out what descriptor is the best, most representative of the pain that you've experienced out of each sort of cluster or grouping of different words for sort of different pain qualities, aching and throbbing. So aching is a less intense form of the same kind of pain family as throbbing, as an example. So I think that captures it a little bit to say what is changing and what isn't changing. In terms of spontaneous pain, some of the families are more about that type of pain. And so the short form of the McGill, it talks about that. And so you can retrospectively apply that to the full McGill to say these are the types of pains that we think are more representative of spontaneous pain. I do think that that's where it is part of the history, trying to listen to what the person's story is and when are you getting pain? What do you do to make your pain better? What makes it worse? But people often will have a sense of, is it something that's all the time? Is it constant? Or is it something that comes and goes for no reason? That I'm not really able to predict that. I think that's where Pain Detect as a screening tool might be useful because it captures the temporal patterns of pain, as well as rating some of the neuropathic qualities. And so as we move forward with doing some research on somatosensory rehab, that's one of the things that is that interim step that I've been desperately trying to get funding for. To look at some of the neuropathic pain screening tools, because a lot of them were developed and validated for low back pain. And that's not really the population that we're interested in, particularly interested in hand and upper limb neuropathic pain, and really trying to use those tools and validate them and say, which is the best one for picking out those kinds of changes and to help us to direct care. So to say, does this person have neuropathic pain? What's the incidence and prevalence of neuropathic pain in a hand and upper limb clinic? There are some studies that have estimated the prevalence in people that have been hospitalized after trauma. That's probably a different population than is attending an outpatient clinic. There's a severity bias there. And so I think we need to be thoughtful about that. And the same thing for an ER department. I think it's pretty hard to actually do neuropathic pain diagnosis in an ER because everything's new and the person has a hard time figuring out what it is even that they're experiencing. They're overwhelmed. So I think there's a need to do a little bit more of a specific evaluation. And I also wonder if something like Pain Detect, which has a few less questions, maybe a little bit more simply phrased and maybe easier for people from a health literacy point of view, versus the McGill Pain Questionnaire, which has more than 70 different descriptions of pain. And that may be biased toward people who have a good command of the English language.
Absolutely.
So I think that that's an important consideration moving forward. I mean, there are many translations that are validated. Spiker would say that's been one of the things that he's liked about using it over the years because he's in Europe and he gets people speaking many different languages that come to his clinic. So he's used German versions and French versions and Italian versions, validated translations of that. But I still think we need to be thoughtful about if we're trying to implement this in standard practice and make it easy for people to do, having something that is going to be a bit more broad, be useful as well.
That's why research takes a long time.
It does.
A lot of considerations.
It does.
Different
right?
contexts.
We'd like to get to the point of doing an RCT right away. We'd like to jump to that. But there's actually a lot of pieces that we're trying to build in place so that we're really planning for implementation. That's really been kind of the theme that we've talked about. And actually, Isabel Kintal, who's another OT who is working in somatosensory rehabilitation, her PhD thesis work is on using somatosensory rehabilitation principles with women with vulvodynia. And she is a co-investigator on a grant that just got some initial funding to look at somatosensory rehabilitation for chemo-induced peripheral neuropathy in women after breast cancer surgery. So it's coming. There's more stuff coming. It's good. But we've really been trying to think about how would we implement this into general rehab practice? What would that look like? What are the ways that people would probably be most likely to use it? What tools? And so we did a focus group with people who were early adopters in the French Canadian community because Spiker came over and taught courses in French in Montreal. And so we've done focus group interviews with those early adopters to say, what do you think is the essential parts that you're using in your practice? What do you think we need to bake into an RCT? But then we also talked with English-speaking therapists who might be early adopters but who haven't adopted it yet, say, well, what would it take? What would you need? What resources would you like to have? What kind of training would you like to have to be able to put this into practice? So we're really trying to think that let's build something that's going to be relevant for clinical practice.
Just one more question, or more the conceptual idea of somatosensory rehab. We talked about allodynia from trauma surgery and upper limb. What about allodynia from nociplastic changes you would see in chronic pain or CRPS? Those that don't necessarily make neuroanatomical sense? Would you still use somatosensory rehab for that?
I think it's always worth a try. There's probably two responses to that. One is we are thinking too big for neuroanatomical sense. For example, CRPS type 2, There's a known injury to a major nerve branch. Well, we know that there may be a crush injury to a minor nerve branch that's never going to get visualized. So that gets lumped under CRPS type 1. But I would also say that there are other times where, again, we're saying, well, what can we do? Can we change the sensory inputs people are experiencing? If there is something peripheral that is feeding the fire, but can we promote spinal modulation? And even in what we were doing, I was talking about, maybe it's further up the arm, maybe there's nowhere on the arm, and maybe actually putting comfortable sensory stimulation on the trunk, on a dermatome that's below that area where that is going to still ascend. And because of convergence on the pathways in the spinal cord, that still might have a benefit or an effect. There's some interesting research in CRPS that were showing that people actually had changes on the sensation of their face when they had CRPS in an upper limb. So we know that there's these sort of interesting patterns of sensitization and almost referral. And so what can we do to calm the system? Maybe it's not the direct neuroanatomical pathway. Maybe it's just calming the system in general. To me, that's the way I think about it is, can I do symptom management? I'm going to minimize the evoked pain. And then can I do system management? Can I just calm the system down? And that might be through a number of different approaches. Again, as we move forward thinking about somatosensory rehab, we're saying, well, what are the complementary things? Like, what are the other things in our toolkit that will work with this and not work against that? Doing joint mobs is not going to be a complementary modality, even if the person has stiffness. But the hope is that if we can resolve the allodyny, if they do still have some residual joint changes, that maybe then they'd actually be able to tolerate doing something like manual therapy that they would never tolerate in their current pain state.
Thank you for listening to part 1 of our discussion with Dr. Tara Packham on neuropathic pain management. If you want to read more on this topic, we've included some articles and links in the show notes. PainCast is a freely available resource for you to advance your knowledge about pain and physiotherapy. We will continue to provide you with top-notch, evidence-based, and practically oriented content. To help more people know about this amazing resource, follow us, rate us, and share our content with your network. You can follow us on Instagram at paincast.psd, where you'll find bite-sized knowledge in 1 to 2 minutes. You can also use the feedback form linked in the show notes to help us improve. Thank you again, and stay tuned for future episodes on pain and physiotherapy.